Welcome to Savita Dental College lecture cast series in orthodontics, biology of tooth movement. Contents: the biology of tooth movement, we will be seeing about physiologic tooth movement and orthodontic tooth movement. In physiologic tooth movement, we would be seeing about tooth eruption theories as well as tooth reaction to normal function. In biology of tooth movement, we will be seeing about theories of tooth movement, histology of tooth movement, optimum orthodontic force, biochemical factors in orthodontic bone remodeling, drug interactions, phases of tooth movement as well as biomarkers. No tooth movement is possible without the periodontal ligament. The width of the periodontal ligament is 0.15 millimeters to 0.38 millimeters. The periodontal ligament consists of the periodontal fibers, the cells, and the tissue fluid. The periodontal fibers are further classified into alveolar crest group, horizontal group, oblique group, apical group of fibers, and interradical group of fibers. The cells are again classified as synthetic cells, resorptive cells, progenitor cells, and others. The synthetic cells comprises of the osteoblast, fibroblast, and cementoblast. The resorptive cells comprise of the osteoclast, fibroblast, and the cementoclast. The other cells that are present in the periodontal ligament are mast cells, macrophages, epithelial rests of molluscs. The tissue fluid that occupies the periodontal ligament space serves as a shock barrier. Physiologic tooth movement. It involves tooth eruption, migration or drifting of teeth, changes in tooth position during mastication. Tooth eruption theories. First is the blood pressure theory. The vascular pressure of the blood vessels within the developing tooth cause axial movement of the tooth. Root growth theory. According to this theory, the apical growth of the root results in an axially directed force that brings about the eruption of teeth. The hammock ligament theory. According to this theory, a band of fibrous tissue exists below the root apex, spanning from one side to another side of the alveolar wall. The fibrous tissue forms a network below the developing root. The developing root forces itself against this band of tissue, which in turn leads to apical movement of the tooth. Periodontal traction theory. According to this theory, the traction of the periodontal ligament fibers leads to eruption of the tooth. Tooth reaction to normal function. During mastication, a load of 1 to 50 kilograms of force is exerted on the tooth. If this force level exists for only 1 second, the tissue fluid transmits this force to the bone and there is no tooth movement. However, if the force exists for more than 2 to 3 seconds, the tooth moves within the periodontal ligament and compresses itself against the bone. Now we will see how tooth moves within the bone. Where an orthodontic force is exerted onto a tooth, the periodontal ligament fibers in the direction of tooth movement get compressed, while the fibers on the opposite side get stretched. In the compression side or the pressure side, along the bone, osteoclasts form and bring about bone resorption, whereas on the tension side, osteoblasts are formed which bring about bone deposition. This alternative, bone deposition and bone resorption, bring about tooth movement. The various changes that take place in the pressure side and tension side are as follows. On the pressure side, the periodontal ligament gets compressed to 1/3 of the original thickness. There is an increase in vascularity due to capillary supply. Mobilization of cells such as fibroblasts and osteoclasts take place. Osteoclasts lie in shallow depressions along the bone called as Hauschup's lacunae and start resorbing bone. As long as a force is placed, a change in trabecular pattern is observed and it reverts back to normal during retention phase of orthodontic treatment. When the forces are within physiological limits, resorption is seen on bone immediately adjacent to the periodontal ligament. This is called as frontal resorption. On the tension side, the periodontal ligament gets stretched. The distance between the tooth and the alveolar bone is widened. There is an increase in vascularity. Mobilization of fibroblasts and osteoblasts are seen. Osteoid is laid down by the osteoblasts adjacent to the lamina dura, and this osteoid matures into woven bone. Based on the magnitude of orthodontic force applied, the changes that take place within the periodontal ligament space vary. In case of light pressure and heavy pressure at 1 second of the orthodontic force application, the periodontal ligament fluid is incompressible, the alveolar bone bends, and the piezoelectric signals are generated. Between 1 to 2 seconds, the periodontal ligament fluid is expressed, the tooth moves within the periodontal ligament space in both light and heavy pressure. In 3 to 5 seconds, the blood vessels within the periodontal ligament are partially compressed on the pressure side and dilated on the tension side. The periodontal ligament fibers are mechanically distorted in case of light pressure. In case of heavy pressure, the blood vessels within the periodontal ligament are occluded on the pressure side. Within minutes, the blood flow is altered, oxygen tension begins to change, the prostaglandins and cytokines are released in case of light pressure. In case of heavy pressure, the blood flow is cut off to the compressed area. Within hours, the metabolic changes occurring, the chemical messengers affect cell activity as well as the enzyme levels change in case of light pressure. Cell death occurs in the compressed area in case of heavy pressure. In 4 hours, there is increased cyclic AMP levels and cellular differentiation begins within the periodontal ligament in case of light pressure. In 2 days, tooth movement begins with osteoclast and osteoblast remodeling the bony socket. In 3 to 5 days, cell differentiation in adjacent marrow spaces take place and undermining resorption begins in case of heavy pressure. In 7 to 14 days, undermining resorption brings about the removal of the lamina dura adjacent to the compression site and tooth movement begins. Optimum orthodontic force. According to Oppenheim and Schwartz, optimum orthodontic force is equal to the capillary pressure, which is equal to 20 to 26 gram per square centimeters. Features of an optimum orthodontic force. Clinically, optimum orthodontic force produces rapid tooth movement, minimal patient discomfort, the lag phase of tooth movement is minimal and no marked mobility of teeth being moved. Histologically, the vitality of the tooth and the periodontal ligament is maintained, initiates maximum cell response and produces direct or frontal resorption. Hyaluronization. It is a form of tissue degeneration that is characterized by formation of a clear eosinophilic homogeneous substance. In case of orthodontic tooth movement, the hyaluronization process is reversible and the hyaline is removed by either frontal or undermining resorption. The hyaluronization takes place in both light and heavy forces, and in case of heavy forces, the hyaluronization region is more wide. When an orthodontic force is applied, there is a formation of hyaline. This hyaline, in case of lighter forces, is removed by formation of osteoclast along the socket wall. The osteoclast resorb the hyaline. The osteoclast also resorb the bone and bring about tooth movement. In case of heavy forces, the hyaline region is wider and here the osteoclasts are formed along the marrow spaces which bring about resorption of bone, then the hyaline followed by tooth movement. This type of resorption is known as undermining resorption. Phases of tooth movement. First is the initial phase where the tooth moves within its socket wall on an application of an orthodontic force. The second phase is the lag phase where there is a formation of hyaline. This hyaline prevents any further tooth movement. The third phase is the post-lag phase where the hyaline is removed by the osteoclast, thus bringing about further tooth movement.